Good afternoon. This is Sarah with the Department of Medicaid. How are we doing this afternoon?
Good afternoon.
Hi, Sam.
It is just now 2 o'clock. It looks like the waiting room is cleared. I believe, Keith, I saw you log on. I
Yes,
believe
ma'am.
also I saw Troy, Joe, and Jacob. Did I miss anyone?
Let's give a couple of folks a few more minutes to jump on. Miss Basham will not be able to join us today. She had some fairly significant surgery this morning. So she will not be able to join us.
Okay. Well, I hope all goes well.
Mhm. Looks like we've still got a steady string of folks coming on.
I get the waiting room cleared and then we get
Close
more.
back up, sure.
Yeah, which is a good thing.
Yep, absolutely.
I did also get the form out to all of the MCOs, and I do have it pulled up if you would like to share it during the meeting as well.
Yeah, once we get through the minutes, we'll go ahead and bring that form up and we'll discuss the other forms that were submitted.
Perfect.
How does the queue look now?
It is cleared.
Okay, let's go ahead and get this month's EMS Medicaid TAC meeting started. We will need to go ahead and establish quorum. So if all the members would come onto video that is able to. And Sam or Aaron, would you mind doing the roll call for us?
Sure. I have Josh or Joshua. I'm not sure which he prefers. Keith.
Present.
Linda's not going to be with us today. Dana.
I'm present.
Troy.
I'm sorry, I'm present.
Joe.
I'm here.
And Jacob.
I am present.
You have a quorum, sir.
Yes, thank you. Thank you everyone for joining. And as we get ready to start, I want to give a thank you to everybody that is involved with the TAC, because based off of the suggestions that we received to take a look at from the forums, it's clear that everybody has been taking a hard look at what we've been submitting and what we've been going through. And I want to thank everybody for that. Now that we got a quorum established, we do still need to approve minutes from both the June TAC meeting and the special called July TAC meeting. Did everyone have a chance to review the minutes that were sent out? Okay, if I will entertain any, all right, motion to accept the June meeting minutes.
Motion.
Oh, go ahead,
Okay,
Troy.
I'm sorry.
motion by Troy, a second.
Joe.
Yep, second by Mr. Pruitt. Any discussion on the June meeting minutes? All right, hearing none, we'll call for the vote. All in favor, signify by saying aye.
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 Any opposed? Abstentions? Hearing none, the June meeting minutes pass. Now the July meeting, is there a motion to accept the July special meeting minutes?
I'll move to approve.
Okay. I'm not sure exactly who that was.
That was Jacob.
Okay, thank you, Jacob. Is there a second?
Second.
Seconded by Mr. Walker. Any discussion? No discussion. All those in favor? Aye.
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 Any opposed? No opposed and any abstentions? No abstentions. The July meeting minutes are approved as well. Jumping into old business, it has been our business now for pretty much since December of last year. We've been discussing the pre-authorization for transport. We have had the recommendations that have come in. And Mr. Walker and Ms. Basham for the TAC have looked at the suggestions that have come in and have put together a suggested form for us to consider as well. So we would like to go ahead and pull the form up that Mr. Walker submitted. It's the form that's up now. I believe Aaron or Sam, did you all have an opportunity to send that out to the MCOs this afternoon?
I did.
Okay, very good. I know it's probably y'all have not had a lot of time to take a look at that, but since Troy was involved with creating this form, and that this mirrors very closely the form that we use for Medicare. I'd like to turn the meeting over to Troy to walk through this form to explain the different parts of it. So Troy, please feel free to go ahead.
Thanks, Keith. First of all, I'd like to start by, we've looked at a couple of different ideas. We've had some of the input from the July meeting and other input, and we've looked at different scenarios and different ways to do this to make everyone happy. We even looked at having a separate Medicare and then a separate Medicaid form. And I'm just going to be honest, it would be a huge effort on behalf of everyone involved, from billing to the ambulance services and everything. If we was to have two separate forms, and remember, this is not billing professionals, this is EMTs and paramedics at the sites, at the scenes, at the hospitals during a time of a run, getting this done. This isn't done ahead of time or anything else. This is done at the time of the call. It would be a huge undertaking if we had two separate forms and filling out the wrong forms for the wrong people, the wrong patients. A lot of times we don't know, especially at the hospitals for emergency room patients, we don't know if it's Medicaids or MCOs, Medicares or what. So we just kept looking at it and decided it would be a lot easier for everyone involved if we had one form that would work for all Kentucky agencies, for Medicare, for Medicaid, whatever the case may be, it would work. And that's kind of why we ended up with this one form. This is the PWW form. This is something that's used by most ambulance services across the state. We took and added the Medicaid number and everything as was stated that was needed. We did look at one time of we talked about ICD-10s and having those on the forms, and we tried that and looked at it, but honestly, there's not enough room to get all the ICD-10 codes on this form. And then once again, it's the same issue. This is your EMTs and paramedics, not billing professionals, that's going to be filling out this form at the time of transport. So we removed the ICD-10 off of this form. But do know that when this is billed, the billing company, when they go to submit this claim, will have the run form, this form, and then the 1500 or whatever they use for billing forms that will be coded by the billing company and have an ICD-10 code with that. So with the billing form, it just won't be on this form. So with all that input and stuff, this is what we come up with. And as far as the top of it, your patient information, date of birth, the Medicare, Medicaid number, the origin and destination, that's all self-explanatory by reading it. A lot of this is what's required by Medicare too. So everything you see there is what's required to prove or to show the medical necessity for a transport. So I guess it's probably going to, instead of just sitting here reading this form word by word, what kind of questions do we have about the form?
Are there any of the MCOs that have not had an opportunity to take a look at this version that we sent out this afternoon? I know it was short notice, but essentially Troy and Linda had taken a look at what was submitted late last week and worked on it and were able to come up with this version based off of the input from the providers.
Troy Stan Brunner from Anthem. Are you looking at this form purely as a prior auth request form?
No, this is at a time of transport that, whether you're at a hospital or a nursing home, it's a non-emergency only
Correct.
that they'll fill out prior to us leaving with the patient. This is not a pre-authorization form.
Is this going to be submitted as a claim form then? On the claim side?
Yes,
Is there going to be other, like, is there a spot for servicing provider? Or is that going to be on a different form with the ICD-10 code?
Dana, I think Dana's on here from the billing company. That's all part of the other billing form, correct?
That's the key. Okay, that's.
Yes, it's part of is it a 1500, Dana, or what?
Yes, yes, the ICD-10s as well as the HCPCS codes will be on the claim form that is sent in, which is the 1500 form for Part B.
Okay.
So, and this is Stuart with WellCare. I would like it. So this will be an attachment to the claim essentially after the fact. And I think within, was it 21 days or something? I think like following Medicare rules. I think that's what we talked about before.
That is correct, sir.
Okay. And I like the Medicaid ID on there. That's very helpful. HMO number.
We
Are
had
there
looked,
any other?
I'm sorry,
Go ahead,
we
sir.
looked at, in section 2, we had looked and actually made a form and tried to get some ICD-10 codes in with some of those things listed there in section 2. And it just really, there's not enough room. That's the gist of it. It was so small you couldn't see anything. And still, Medicare doesn't require the ICD-10 codes. So it would probably mess us up and cause some issues with Medicare, but it's just better off if the ICD-10 part, having a billing professional, an official certified coder for ambulance billing, coming up with those ICD-10 codes and not something being picked from a cruise while they're on the scene. So that's kind of why we like using that billing form, the 1500, instead of using this for that.
Is that Medicare's process that they submit for that? You submit the claim and this form. Is that how it works?
Mhm.
Yes, for the most part. Isn't that correct, Dana? For all Part B, this is how it's done.
Yes. Mhm.
Okay, so it's an
For
attachment.
Medicare, it is. Now, well, let me back up a little bit. Medicare doesn't require us to attach it to the claim. They require us to have it upon request. So, and before we
Gotcha.
submit the run, but we can certainly attach that to the run to the Medicaid payers, if that's something that you guys want it to be done up front.
And this is Dan Brunner again, Anthem, that the provider information, the servicing provider will be on that, as you said, form 1500 attached with this?
You're talking about the EMS servicing provider, correct?
Correct. So
Yes.
that way we know who to pay.
Yes.
Yeah,
Your
that's
15
important.
Yeah, you would receive your 1500 or your electronic claims just like you always do. And then we would just attach this form with it.
This is Jeremy Randall with Anthem. Just a follow-up question on that. So we'll still need to build an authorization before the claim or the 1500 is submitted. So to build an authorization, we need to know who the servicing provider is going to be. So is there potentially room, or how would that communication be sent to us?
Well, if it's sent to you guys at the time that the 1500 is, we wouldn't have the authorization built in until you actually receive the claim. And I believe that is the goal that they're trying to accomplish here, is so that they are not having to do all this upfront work before they can submit a claim to get paid. With Medicare, we don't call ahead of time. We don't get an authorization ahead of time. If it is a non-emergent run, this form is filled out to support the need of medical necessity, and the claim is paid by Medicare.
Jeremy, this is Divya Canner. If I could just share some of the conversations that I've had on our internal side here at United Healthcare. A prior auth has the implication that it could potentially be denied. And emergency transportation by regs and by our contract can't be denied. And specifically for this, our legal advice was, and I'm trying to make sure I say this correctly because I'm not the lawyer here, but it was a hospital to hospital transfer could be considered not necessarily emergency, but urgent. It's important. It's the only way to get that patient from one place to another is through the ambulance service. So it's medically necessary. And we would never deny that. So that we chose to not use that term prior auth.
Correct. Divya,
For
we're
that
with you on
reason.
that, yes.
Yeah. So we're not going down the road of
Prior auth, no.
requesting the prior auth.
Right.
The reason for this PCS from UHC's perspective was more from an audit. Please transfer the member patient. Please do that. We need to be able to prove a year later, why did we do that? Why did we pay for this service? So this form helps keep us honest. And that's just trying to reduce some of that bureaucracy around that.
That's a good way to make the distinction. I think, when we first started down this path, the chair of the EMS TAC would call it a prior auth form. And I kept stressing that we don't require prior auths for these. I don't know, my colleagues did, it sounds like you're in the same boat. We just want to make sure everything is properly submitted post-service on the back end to make sure the claim is appropriately paid.
Yeah.
That's all, that's the key. That's where we are as well.
Yeah, great.
Dr. Galloway,
Yeah.
from the perspective of Humana, I know you had some concerns last month. Has what we've talked about satisfied that concern, or did your all's group have anything else further that you wanted to bring forward?
Well, I think we, like United, of course, we don't require any kind of prior authorization for emergent. Those are always paid. And we also, pay the facility to facility transports, even when they're not technically considered emergent. The ones we look at are facility to home, type or elective home to facility that's not going to the ER or something. Those are the ones we have looked at in the past. And, we are fine with this form. We're fine with getting it on the back end. We are still going to look at facility to home transports. And, we are going to need like the run sheets and any other information, to support what's on your certification form. I mean, we still will be looking at those, but yes, we're fine with you using this form.
Sure, and I don't think that you'll find any EMS service that will try to say, well, no, we don't want to give you that. That's not been the intent of this from the get-go. I think everybody, all the services that are even on this call, EMS services, if there's a reason to suspect that there's a problem with the run, we want it looked at. We don't want anything that looks out of place in the slightest. So if it deems that it needs to be looked at, then it needs to be looked at. Just that simple. It's just that with that prior auth form that we were all presented last August, that was going to be a major and was a major impedance to being able to get the claims paid, because we had to have that form submitted before you could submit the claim form. And usually we got the claim form submitted before the pre-auth got submitted, which automatically knocked the services out from being able to get compensated, which created another problem in itself. So I think just the fact that we're moving in the direction that we are of being able to accept this form, turning this form in at the same time that the run form is turned in, as is the 1500, is a step in the right direction. Dana, from the perspective of being our EMS biller that's on this call, is there anything from your perspective that we haven't talked about that we should be talking about? From your perspective?
Yes, I just actually was going to jump in here. I just want to clarify with all the MCOs that if we all agree to this form is used on the front end, that our claims will not be denied if they do not have a authorization number on the 1500 form.
No, with Humana, we can set them up to be looked at on the back end when the claim comes in. And like I said, as long as the appropriate form and the, you know, clinical information is attached so we can look at it, then, you know, we will, you know, proceed with, you know, reviewing it and paying when appropriate.
And I think it's
Same here for
important
United.
to note also that this is, I know, this is not just for interfacilities. This is all non-emergencies. So it's the same exact form that we'd fill out to go to a residence or another hospital or to a nursing home. So I just want to make sure that was clear. All those non-emergency transports, this is the way we do it, or would like to do it.
Yeah, correct. Thank you.
Yes.
Yeah, and I spoke with staff at WellCare. We're fine with no auth, and it'll be a claims processing process. They will look for this form. They'll deny if the form's not attached, but that will be their process.
Yeah, so I think at this point that as long as we've got everything that we have said that we would provide you all, then that would be on us. If we don't turn in the form, then it's clearly on us. So it shouldn't be a problem. I believe Aetna Better Health was the other MCO that had some concerns. Is there anyone on the call from Aetna Better Health that can talk from their end if once you all took it back, if there were any issues with doing it this way?
Yeah, this is Dr. Main. No issues. Just to make sure that this would be submitted with the claim to help necessitate the transport. You know, it's not a prior authorizable service, which I think we've kind of talked about just now. And the only time that we really would need a prior auth is if it were from a non-PAR provider or somebody that wasn't in our network or going out of state or something. So on the back end, yes, we would need this form to help substantiate medical necessity, but that's just working into our processes. I don't see an issue.
Fantastic. Troy, is there anything that you can think of that we need to point out further, or any other discussion about this form from your perspective?
Just the fact that, you know, if there's we can't add a lot more to this form because it becomes so difficult to start filling out. I mean, I got to wear my cheaters just to look at it on a computer. So if there's a piece of information that the MCOs or something really would like to have that's not on there, just, you know, that would help in this process, please let us know. There's not a lot more we can add, but if there's little things, we might be able to still add to the form. If it's something that's holding you up, just I think it's a good time just to let us know so we can be working on it.
Right. Dr. Cantor?
Thank you. No question about no addition to the form, but my question is more around how many days. I heard 21 days, or is it 30 days till we have it with the claim? What kind
Dana,
of lead?
can you address that?
Yes.
How that works?
No, most of the time the PCS form is gotten at the time that they get that at the time of the transport. However, Medicare's rule is if you do not have the PCS at the time of the transport, you have 21 days that you can obtain that PCS form from the requesting physician or facility. And then if they still don't provide it to you, you can file the claim with a what we do is we file it with the certified mail notification that we actually sent and try to acquire it, and they will still accept that claim without it. But as far as this is concerned here, the PCS forms should be attached at the time the claim is filed.
Well, are we going to offer some grace? We're all human. Sometimes things happen.
Yep.
We'll take any grace that you happen to throw our way.
I mean, wouldn't it be fair to offer up at least the same 21 days?
Yes, that would be fantastic.
But I'm just speaking as a non-person, as a person who doesn't run the claim. I'm just speaking as a.
Yeah, are you going to follow, if you do that, if you allow us the 21 days and we are not able to obtain the PCS, or the service isn't able to obtain the PCS, are you still going to pay the claim with the proof that we've tried to obtain it from the treating physician?
That is something that we have not discussed as a group yet, but that is something that Medicare does do. And again, that falls back to where, for whatever reason, the EMS service or the EMS billing agency has requested the information from the provider. However, they just haven't responded back. So let's say a crew, and this is something that happens real world. The crew leaves the facility with the patient. They realize they forgot to get the signature. They get back to the EMS station. The form gets handed off. Then somebody has to go back, find the doctor that was on duty or the nurse that was on duty that called and scheduled the transport, try to track them down, get the form filled out. By then, they may have already left for the shift. So then we have to file there is a process that gets involved. And most of the time we could probably get it done in 21 days, but to say that it always gets done in 21 days would be a stretch. In fact, there's going to be times that it may not get done because, you know, you look at people's vacations that
Sure.
come into it. There's a variety of reasons why it couldn't get done. But if the MCOs were to feel that it would be appropriate, if it is not attached and the EMS service has reached out and can verifiably show that we have reached out trying to get this, if you all could give a little bit longer time frame to say we're not going to deny it yet because we know that we're still trying to get it, that would be fantastic.
So this is Edna. I don't know, the details enough on the claims process with the forms, but I feel like if it's in the contract and there's something that speaks to this process, we have to follow the contract. So if it says to submit all forms by 21 days, and we're going to have to live by the contract.
That was my question as well, Dr. Mann. Is there anything, and I don't know, I'm asking, is there anything specific?
Yeah, I know you have a full year to submit claims, but I have to check the window of time for associated paperwork. So I'm just, while I definitely understand there's issues in trying to get things, but we have to follow the contract. And so whatever the contract says is what we're going to have to abide by.
I think in theory, it sounds good. The only problem is we set up rules, claims processing rules, try to automate everything. And so that's what I'm just thinking, accommodating, if there's no form, but good faith intent, when somebody's just actually processing the claim, they would have to set up a process to accommodate that, which could be a challenge, but I mean, it makes total sense. But I could just see you got somebody working claims and, that would just, they would have to be.
Yeah, and I mean, there's like I can totally understand, but exceptions start to make.
Yes, exceptions start to make things harder. There is one other condition that requires a form, and that's if a provider completes an abortion, there's a MAP 235 form that has to be filled out, and we all have those monthly or those quarterly state reports to that. So it's possible. And yes, things are very highly automated here as well. So I would just need to tell our claims people, when could they expect this? Is it 30 days? And that's why we have appeals as well, because sometimes we don't get it right the first time for various reasons. We don't have enough information, what have you. So appeals are always there, but we sure do try to get it right the first time, as I know you are too. So I'll just throw out there the 30 days because I'm not sure what the contract says either for associated forms. But I think if we wait a year for this form, it's even harder. At least
I
in
think
30
I might
days.
need, I think I might need to clarify something here. When I say that Medicare allows us 21 days from the date of service to acquire this form, the claim that is going to Medicare does not get submitted until either the 21 days have passed or until we receive the form. So we hold the claim until we actually have this PCS form. And then the claim is submitted, either since we have the form or since
Okay.
we have the, so you wouldn't get a claim and then be waiting for this paperwork to come 21 or 30 days later. We wouldn't submit the claim until we have the paperwork. And then we know that we have 1 year to submit our claims from the date of service, or we've gone beyond timely filing with Medicaid.
Okay.
Make it easier.
Make sense?
That makes a lot more sense. Yes.
So
we-
basically you're saying that you feel that that 21 days is adequate time for you to obtain all the documentation before you submit the claim? Is that what you're saying?
That is what what I say is that is what Medicare allows us at 21 days. If we still don't have it, then we can go ahead and submit it with that proof that we tried to obtain the form.
I think this
Does
one,
Medicare pend until you actually submit the form? Do they do anything like that, or they still go ahead and pay the claim even without the actual form?
Well, it's
They
in process.
as
so-
long as they feel that the claim meets medical necessity, yes, they will go ahead and pay it.
With the attestation basically that you tried?
Yes. Mhm.
Okay.
I think some of our biggest, I know you gave an example a while ago, Keith, but a lot of time especially with the ER transports is the biggest problem that I see. A lot of times the hospital will get a patient and then we'll transfer them out later, non-emergency. And they'll put down on the face sheet that it's a Medicaid. And you got to remember that our ambulance services across the state, they don't have access to registration at the hospitals and things like that. They get a simple face sheet. They drop the patient off. The registration staff give them a face sheet of what they have at that moment. Okay, so they get there at that moment that they're brought to the ER, and they just say, well, I've got Medicaid, but that's about all they know. So they put Medicaid on the face sheet, and that's what my crews get. So we're processing, thinking, okay, it's not an MCO, it's just Medicaid or Medicare. And then we find out 2 weeks later that after they've done some checks and they run all the stuff they do in registration, oh, wait a minute, this was maybe, for example, a well care. Okay, well, we've done transferred this patient thinking it was just Medicare only. And now we found out that it's Medicaid's well care. That's the kind of stuff we have. Just remember that we don't have contact or anything. A lot of your services don't. They get a simple face sheet and it takes a little time. So that's where you'll see some of the not getting the PCS form filled out at the time of transport, and we need that 21 days. I just wanted to give as an example, just to make sure you was aware.
Now that's a good point, Troy, and our billing services really are our best advocates for EMS to help go back and get much of this information. Because to Troy's point, once we go to pick up a patient, we have to take what we get off the face sheet, and it's even getting to the point that some facilities don't even want to give face sheets to EMS because they claim that there's PHI or HIPAA on the face sheet that we're not allowed to have, but yet they're turning the patient over to us. So we run into the different circumstances all the time trying to get some of this information put together.
So, but this would definitely be a lot easier, and we could manage this a lot easier than we can those pre-auths, because you got the same problems, but you're trying to do it ahead of time. So this is a big step, and I'm super happy to hear the comments we're hearing today about this form and approving. So.
And to that point, I would like to ask, and I may have to get the Medicaid services folks to clarify, what do we have to do to memorialize what we've all talked about and agreed to here to get it to where everybody knows it's copacetic and this is going to be what we can send out to the EMS providers and billing companies is what the process will be. what steps do we need to fill out? I believe last time we spoke, one of the physicians spoke up and said that there is a process form that we have to fill out through our Department of Medicaid Services to accept the form. I'm not exactly sure what the process is. So anybody who happens to know what we need to do to get this done, please feel free to educate us.
Angie, are you on the call?
I don't believe that she is. This is Leanna
Oh.
Trainer. I can take back whatever question you may have for her.
We were, sorry, excuse me. They were just curious since the MCOs are working as a whole on the one form to get it approved, Leanna. Will each MCO need to submit this to DMS or can it be submitted as one for all of them? I know you and Angie have worked on that process prior.
Yeah, so typically we'll come up with a template and then we'll just ask the MCOs for their information and we'll plug it into the template and then distribute it to everyone else.
Thank you.
Keith, I do have one more question about the form.
Certainly, go ahead.
One thing that's on this form, and we do use it for the Medicare side, and something I wanted to bring up just to make sure. In section 1, transport date, and this is valid for round trips. So what they allow, say we pick up a patient at the nursing home and bring to the hospital to get an x-ray, and then we take them right back to the nursing home. This one form would be good for both trips that day. That's one section of this. I don't know how y'all feel if that would work for you all as well. But also, if y'all could scroll down, whoever's hosting the page. This has for Medicare, once again, they have a repetitive patients. So it has to have a physician's signature on it. Where most of the time we're picking up a patient, taking them home, taking them to another hospital. Any of those listed at the bottom can sign this. PAs, registered nurses, social workers, whoever. But if you want to do a repetitive transport with a 60-day valid or 60 days, you have to get an MD to sign that. And that's part of the form for Medicare. And I just wanted to make sure and see if Medicaid was interested in anything like that, or if that would work for them for anything. The repetitive runs have to be the dialysis, wound care for a 60-day span instead of having, let's say you're transporting the patient 3 times a week, and that's 2 times a day. So 6 run forms and claims. Would one form be okay for 60 days, or would you like that for each transport?
Hi, Troy. This is Wendy McNamara from Aetna Better Health of Kentucky. And I think we talked about this a couple meetings ago, but my recommendation at that time was, in our opinion, by definition, that is a true prior authorization request, I feel like. And I think I would encourage say dialysis providers, for example, put that on them to obtain the true authorization for X number of transports. So I don't know if there's a way for you to collaborate with your dialysis providers or something of that nature, but that would be our suggestion, because it is a true prior authorization request. If you know that there's going to be trips needing to be set up in advance, and then that way you would have to just have one form, call in a case, X number of trips, and you have an authorization form that you could use with each time you submitted a bill, a claim. Does that make sense?
I just don't know of many dialysis centers or anybody that would do that for the ambulance service. Case managers to the hospital.
Yeah. The hospital, somebody should be helping coordinate care. And I don't know if maybe there's an opportunity for us to take that back to some of the JOC meetings that we have with providers. Maybe if all of our MCOs could do that, and maybe we, try to have a process change that way. But that seems to be the most logical solution to avoid the EMS billers having to submit that, those multiple claims each week when they're transporting that patient 3 or 4 times a week. Would that help you out?
Dana, I want to kind of lean on you for that one. We've never done it, so I don't know.
For- I mean, it's the same price. I understand what she's saying, but there's a big portion of runs that you guys do that are these repetitive runs. And that is one of the reasons that this whole prior authorization thing, we were trying to get it down to this.
I just don't know who would do it. I mean, that's a good point. I could see what you're saying, but we've just never had anyone that would help us do pre-authorizations like that.
I mean, yeah, if it's something that I get what you're saying. I don't think that the nursing homes or excuse me, I don't know that the dialysis centers or the wound care centers would be doing that. It's not something that we couldn't do as a billing agency, but I can't really speak for, the other billing agencies in Kentucky, but we're familiar with it enough that if we had the PCS form with all the information on it, that we probably could contact and get the pre-authorization once we know that those repetitive trips are going to be made.
And Dana, I'll even go as far as saying, I think when we spoke about this the last meeting, we talked about maybe if you had to bill in 1 or 2 trips, let's say you establish a rapport with a patient and the dialysis center is intending on using a certain EMS provider. If you had to submit in 1 or 2 trips that you've had to transport them, but knowing that you would be continuing services, that would be, reasonable for you to have to submit that 1 or 2 trips until you got that PA requested and reviewed and all of that good stuff. But at that point, I feel like it could provide you with, maybe up to a year's worth of an authorization. And just need to get it renewed every year or something like that. I don't know. I'm just hoping that might help some of the administrative burden for the companies, for the billing departments.
I think it's something that we would definitely, as a billing company, what we would have to do is we would have to reach out to a couple of the dialysis centers and wound cares and just see because on our end, we're not going to have the dialysis centers tax ID or their Medicaid provider numbers. We just don't have that. And those are things you have to have in order to get the authorization. So it would have to be a joint effort upon us as a billing agency and the dialysis and wound care centers for those repetitive runs. Now, as far as the first couple of trips, Medicare's rule is that they don't consider it repetitive until the 3rd run. So when you make that 3rd trip, then you have to have that repetitive PCS form. So you have the first 2 to gain all your information. And then by the 3rd trip, you have to have it all lined out and done. So again, it's just going to be how willing the facilities are to work with us as a billing agency to give us that information in order to acquire the authorization if they're not going to do it.
And it might be something we do this in steps and start with this and get this done and on the way. And that could be a topic, for this committee in the future.
Yeah.
It's definitely something that we can help with on that, but I think Troy's right. I think if we can get this done for this first step, just get these non-emergent runs straightened out, get them filing correctly and paying correctly, then we can move on to the repetitive information.
All right, very good. This has been fantastic, folks. I got to tell you, I think that going into this, most of us from the EMS world weren't sure how it was. We really, honest to goodness, had no clue how this was going to turn out. And this is, I think, better than anything we could have asked for. And this is fantastic. What I would like to do is if we could get this process in writing, laid out to where we're all consistent. We all know what we're going to do. The Kentucky is having an EMS conference in September. It's the Kentucky Ambulance Providers Association's conference in Lexington, the week of the 11th through the
15th.
15th. And I would love for us to be able to roll this out as a project that we were able to do. MCOs, EMS, Kentucky Ambulance Providers Association, everybody that came together to make this happen. I'd like for us to be able to make the announcement and be able to say, you know, what it is that we've all agreed to here today, so that people can understand what we need to do going forward in order to get the claims paid. And this will be a huge shot in the arm, if you will, for our industry. So from that perspective, from Medicaid services, as far as actually having something in writing saying what the process is that something that we could see come from your all's office? Is this something we need to draw up? What do we need to do here to make sure that we're doing everything consistent with what all we spoke about here?
I will
So-
take that back on the DMS side, and run that through, upper management, and titles bigger than mine, to find out what that exact process is for you. And, I do have the form, and I'll send that along with it. And now, as far as writing the process down, that may be something that, they'll have to get with the MCO. But I will start working on figuring that out and let you guys know.
Okay, and
So-
I hate asking this, but on the title on the screen, it just says Kentucky Medicaid. Is that
Oh,
Aaron or Sam?
It's
or-
Aaron.
Okay.
It's
thank you,
Aaron. Is Sam Kelly, by the way?
Oh, okay.
No, okay.
So can we make a formal motion from this TAC committee to move forward with presenting this document to Medicaid or whoever? Do we need to officially do that as a motion?
It wouldn't
I-
hurt. Sorry, this is Aaron again.
So moved.
I think that would be appropriate.
I'd like to make a motion that we take this form as presented and move forward with it with Medicaid and whatever the process is to get it going.
Absolutely. We have a motion on the floor, second by Mr. Pruitt. Didn't even have to ask for a second on that one. Thank you, Joe. Is there any further discussion? With no other discussion, all those in favor signify by saying aye.
Aye.
Opposed? Any abstentions? Very good. Motion passes. Again, folks, I cannot tell you how appreciative I am, and the committee is, of you all being willing to work with us in doing this. This is huge. So thank you all very much. Okay, let's drop down to item C under old business, which we had touched on before, which was any potential updates to the payment grid for EMS for Medicaid transports in 24. Not sure if there's anyone on the call that can speak to that. I believe Mr. Bechtel was the one who spoke last time to it, but not sure if he was going to be on the call today to where he could address it or not. And since he hasn't come up, I'm assuming he's probably not on the call, so we'll carry that over to the next meeting. Jumping down to new business, we've all heard and there's been discussions at some of the meetings I've attended at the Capitol Annex recently, talking about potential legislative initiatives for the next session. And we hear bits and pieces, and I've heard bits and pieces about, there may be a look at potentially raising the EMS rates for Medicaid during this next legislative session. But then I've also heard that that's not going to happen, that they would want to do it in any kind of an adjustment through the GMT program. And what I wanted to throw out there is there, from any of the Medicaid folks that are on the line, do you know if there is anything that is being discussed that can be discussed openly about any type of legislative initiatives that are going to be suggested for the next legislative session in Kentucky this fall? Aaron, I'm not sure if the deputy commissioner or anyone like that is on the call that could address that particular matter.
Aaron, this is Leslie.
Oh.
I was gonna check to see if Justin might happen to be on. I don't think I can talk about specific raises or anything like that today, but we can definitely get information back. I know Lisa, Commissioner Lee did present, I believe it was at Health and Welfare or one of the recent meetings about upcoming legislation. So I don't want to speak to that unless Justin happens to be on and he knows, but we can get information back to him.
Okay, yeah, if there's any chance that we could get some information specifically before September 11th timeframe, because again, we've got the conference that's going to be going on in Lexington where we will have probably more EMS providers in one location during that week than what we typically ever will anywhere else during the timeframe or during the year. So if there was any information that we could give out that we know is legitimate, good information, we would like to be able to give that out to the providers. And so that Kappa may do the same for the Kappa membership as well. So anything that we could get would be fantastic.
Aaron, just propose that question back to Commissioner Lee, and we don't need to have a recommendation or anything. I think we can get you an answer fairly soon. And I believe Leanne and I will be at a training or conference coming up soon that we might be able to give you some information as well.
Okay, that'd be fantastic. Thank you very much. All right, dropping down to item number 6 here, general discussion. Is there anything that any of the MCOs would like to bring up? Anything any of the other EMS committee members would like to bring up that we haven't discussed as of yet? I think the only thing I would like to say going forward at this point is to the folks that do the minutes for us, that the state provides, kudos to those folks, because how they can get every word that we all say and it all comes out looking very nice on the minutes. Kudos to you all for being as good as you are. In a million years and on my best day, I would never be able to keep minutes the way you all do. So thank you for what you do.
I will
while you're
pass that
listening in.
message to our reporter.
Very good. Thank you. Thank you. Okay, hearing no other general discussion, our next MAC meeting is scheduled. The next MAC meeting is scheduled for September 28th from 10 to 12:30 for those that are so inclined to jump on that call. As far as recommendations, I believe that unless the group states otherwise, I think that we can take forward at that MAC meeting that this group did vote to make the change going forward. I'm not sure if that is going to require an actual vote or anything on behalf of the MAC. I think this is something that we've been able to accomplish ourselves within this group. And it's going to be more from just an informational standpoint. Troy, would you agree with that?
Yeah, I think so. I mean,
Okay.
I don't know if it's still needs to go to MAC or not. I don't know about that procedure. But
So technically, any recommendations, it's up to the TAC if you would like to make that recommendation. However, since this has been an ask of the TAC and the MCOs are all moving, working together, moving in the same direction, you can keep it as an ask of the TAC since it's working. If you feel that you would prefer to make it a recommendation to go in front of the MAC, that is completely up to the TAC members.
Me personally, I am just tickled pink that we've been able to get this taken care of at our own level, and happy keeping it at this level, quite honestly, if the group agrees.
I agree with you, Keith. If the MCOs are good with it, I think we should keep it here.
Yep.
Yeah, I go along with that.
Awesome. Very good. Very good.
The MCOs will speak up as needed at the MAC.
There you go. There are some lively conversations that take place during the MAC. I will say that. No doubt. All right. Our next meeting of the EMS TAC is October 30th. this year between 2 to 4. I will say that when we get all of this put together with what Aaron and Medicaid comes up with, if for some reason we need to get together for some reason or another, I'll call a quick special meeting just to be able to make sure that the writing is exactly the way we want it to be, so that we get it precisely correct. But otherwise, if everything seems to be flowing fine with no issues, then we'll just plan on having our regularly scheduled meeting on October 30th from 2 to 4. With that, if there is no other business, we will call for adjournment. Can I get a motion from anyone for adjournment?
Motion.
All right, motion from Mr. Walker for adjournment. Is there a second?
Second.
Second from Dana at A&B. All those in favor?
Aye.
Opposed? Motion carries. We are adjourned. Thank you all very much so much. And I hope everybody enjoys the hour back in your schedule for the day. Thank you all so much.
Thank y'all. Everybody have a good Monday.
Take care.